Welcome to the Auburn Medical Group YouTube live stream, the entertaining medical live stream where viewers can ask real-time questions of real medical doctors. And here are our hosts, Dr. Mark Vaughn and Dr. Gwen Vaughn.
Excellent. Let's start the show. Let's just jump right into it. Dr. Mark Vaughn, Dr. Gwen Vaughn.
That's me.
You can tell I'm Dr. Mark because
it says your name on it.
Yeah, at the Auburn Medical Group. Isn't that cool?
Oh,
is this the first time we've worn this on the show?
It may be.
So welcome to the show. This is a medical talk show of sorts with a live audience. It gets to chat in, and you'll see the chat here very, very briefly. We'll get to it. You'll be able to ask your questions of the doctors or comment in on the show. Yeah. And already we have Laura Webb, who says, "Good evening, doctors." Good evening, Laura Webb. And also Robert Antonio saying, "Hi, Doctors On." Hello, Robert Antonio. Thank you for being a part of the show. We're glad.
It's a paradox.
I apologize we didn't have a show last week. It's because there was only one of us, and man, it's hard to carry a show by yourself. I mean, we've done it before. And,
yeah, I was
and
on
actually,
vacation last
sometimes
week. Actually, last week on Monday, I would not have been good for, or I may have been really entertaining.
It's some kind of a medical topic?
Yeah. Well, no, I'm just saying I
remember
had
now.
come out of a medical procedure, so I remember still maybe a little
what you were doing
little
now.
woozy.
Yeah, yeah. It doesn't hurt to sit?
No, it doesn't hurt to sit.
Okay. We want to make sure. And then also we have Cheryl Bos saying, "Good morning from the UK."
The UK, it's already morning.
I was going to say, it's morning in the UK? I guess
like early
like
morning.
Like 1 o'clock a.m. or something maybe. We'll find out, I'm sure, pretty soon. So that's why there wasn't a show last week. But we are glad that Dr. Wayne is looking like he's doing fine. And he got through.
Good report from my doctor.
Good report from his doctor. See, even the doctor goes to the doctor.
Hey, what do you know?
We encourage you also, when it's appropriate, to go to the doctor, do your recommended screenings and preventive care. And if you have chronic illnesses, do the things
stay on top of those.
Yeah, do those things, especially the lifestyle things.
Yes.
Diet and exercise, so that you don't have to take a bunch of medicines. Maybe you could even see the doctor less often if things come out really good there. So that's kind of the thing that we hope for.
And while we enjoy what we do, we won't miss you.
Yeah. There's plenty of patients. Believe me, there's plenty. Even in the UK.
We enjoy seeing you, but we enjoy seeing you well.
Yes, we want people to be
healthy.
Well. Yes, we do want that. Kind of like the dentist, that
that's right.
Got people to use fluoride and brush their teeth and kind of
didn't need them
drove themselves out of a job for the most part.
Yeah, if we're doing our jobs well, you should be seeing us less.
Yeah, we need to reopen all those dental schools that closed as medical schools to try to get.
Oh man, yeah, we need more doctors.
Turn out some doctors to see the people who are going to need them, or already are needing them, and are going to need them.
Yeah.
We have this trend upward of people needing doctors and doctors retiring, so that the number of doctors relative to the number of patients is shrinking. And it's projected to continue as the baby boomers continue to
get older,
get to the age where they have
medical.
Yeah, that was it. 4,000 people a day
enter Medicare.
Turn 65.
More than that,
in the United States, I think.
Oh, it's got to be more than that.
It might be, but we're not putting out doctors at a rate high enough.
4,000 a day
to keep. That'd be a couple doctors, right?
Yeah.
No, a couple primary care doctors is what that would be.
Yeah.
Are we putting them out that fast?
No. I mean, some of them already have, so you wouldn't need that many. But maybe one doctor. Are there how many doctors?
It depends on how many residencies there are for primary care.
I'm trying to make some calculations in my head. I don't know.
I
know they say we're going to be behind, and we already are behind.
Yeah.
That's what I know.
So how's that problem solved?
How is the problem solved? Well, they're trying to. So there are a lot of new medical schools popping up. Some of them, kind of.
There's such thing as 3-year medical schools.
Yeah.
Putting out doctors.
Getting people through. And actually, I think some of those are like specifically for primary care. Like you go in with
thought that too.
That was supposed to be a thing.
And I talked to somebody that was more aware of it than I was. And they said not all of them. I mean, there's not a requirement that they be that way.
Right.
It's kind of like PA school where there's certain things that you can just drop out, and clinically you're really not going to see it.
Yeah.
At least not in primary care.
Let me get on a soapbox a little bit here and talk about why we're going to have a bigger problem as time goes on. So currently, medical school is very expensive. And there are some that are not, but the average medical school debt of people coming out is over $200,000. I think it's $240 or something like that. That's the average.
There are some that are much higher.
I just talked to a resident today who is approaching $600,000 in student loan debt, which is amazing in a bad way.
Wow.
So keep that in mind. When we talk about doctors who do procedures make more money than those who just work in an office, talk to what we call non-procedural medicine. As primary care doctors,
Who calls
it is
I've never heard that before.
It is a non-procedural.
It makes sense, though.
Yeah, it's a non-procedural specialty. We do procedures, but for the most part, we're
It's the first time I've heard this, and it's funny to me.
yeah, okay. But anyways, for the most part, we're sitting down having a conversation with you about your health, trying to get your medical issues under control, diabetes, cholesterol, blood pressure, etc. That does not pay as much. So if you're coming out of medical school with hundreds of thousands of dollars in debt, and you're looking down your possibilities for what your options can be for
I can't bring myself to tell them to do primary care.
Yeah, how are you going to do primary care where we make, half as much as
a specialist?
As a specialist.
Somebody who's done a fellowship.
Right, where you're going to be able to pay off those loans more. Now, let me take that one step further and say that now there are these student loan repayment programs through the government, and they require you to do 10 years in a specialty or in a area of need or working for a nonprofit. Most residencies are already those nonprofits, so those count towards those 10 years. If you go into a specialty, you can extend that, and in your residency, you can get 5 years as a surgeon, longer if you're a subspecialty surgeon, of that time towards your loan repayment. So why wouldn't you go into a specialty where you can stay in residency for 8 years, get 8 years of your towards your 10 years of loan repayment, then just do 2 years at a
Wherever you, yeah.
At a low
some place
place
less
of need.
attractive.
Yeah, and then move on to your highly lucrative career.
Really?
Yeah, this is the problem with modern medicine and the track that most and loan repayment and what I was once going to write a blog on this, but I never got around to it. So I figure I'll just talk about it here. But yeah, it's a problem in my opinion that there is no incentive for graduating residents or actually graduating medical students to go into specialties that are going to be primary care.
I did not know.
There's actually a disincentive.
Did not know that the problem was compounded by the loan forgiveness rules. Letting the specialty residents and fellows get the break that the primary care doesn't. Well, the primary care gets it for the 3 years they're in residency. How interesting!
3 years versus
So we've got work to do.
Yeah, so that is, and we need another doctor at our office. We have been looking for one for years, a couple of years now, and now. Because we are independent physicians, we are doubly against. How would you say that? But we are. It is even more difficult for us,
right?
Because
the recruiting problem.
We're not a big.
We don't qualify for the loan.
So you can't do the loan. That's one thing. And then in the way that we practice medicine is a little slower paced, and because of that, actually our reimbursements are about the same, but people look at it and they just look at base pay, not value-based reimbursements. Typically, when you're looking at a job, so I don't know. There's a lot of things.
Interesting.
A little bit of a soapbox there. Sorry, get me going.
So
but
there are people who are loan forgiveness agnostic, and that would be people who either went to a super affordable medical school or maybe their family paid for them to go through medical school, something like that. There are people like that.
Is
or got
pretty
some
minimal
kind of
loans.
Great scholarship unrelated to an obligation after. There's not that many people like that. And if there are any of them who want to go into primary care,
or you
please
did,
call us.
your military, and you did your military service, and then they're done. That would be one way to do it.
Yeah.
I'm trying to think of other ways people got their loans paid for in medical school.
So there are some. Okay, hey, look at this. We got Lindsay Antwine on the program, and we encourage you to be like Lindsay Antwine and look at our Patreon. Let's see, where do we see the Patreon here? Is it here? Look at that.
Hey,
that is how Lindsay Antwine gets so much attention from us, and you can too. So Lindsay, no one can afford. Well, yeah, that's what I actually just commented on. Is there's a few.
Yeah,
they do exist.
Right.
But yeah, we both had to pay.
I took loans out for medical school. All of it. Literally every single penny that I paid for medical school.
I did all but the $2,000 that my folks contributed to.
Wow. That's good for Grandpa and Grandma.
Thank you, Grandpa and Grandma, yes. Yeah. But the rest was all loans.
Yeah, I think they helped me out a little with, but not med school. My parents got me through undergrad, which I am wholly grateful for. That I didn't have any undergrad loans. I am
that was helpful.
Yeah, absolutely.
Okay, so
anyways,
thank you, Lindsay. Yes.
My little soapbox there.
So I guess that's the subtopic of the show then, since that's what the comments and questions have been toward. So it is quite a challenge, as we do have the increasing need, decreased supply. One of the things that we do to try to address, and I think we've talked about this on the show before, is the use of physician assistants and nurse practitioners.
Yeah.
Impaneled in primary care. I commented earlier about what is it they take away from the PA program, those things that don't really have that much application in actual clinical practice. Some of the more in-depth biochemistry that in day-to-day practice of medicine, you don't really get into that, or some of the stuff in microbiology or like embryology. How much does embryology actually make your practice
currently
daily with your patients? How much different would it be had you not had?
Yeah.
I mean, would it
on a day-to-day basis? Pretty minimal.
Absolutely minimal. I mean, there's some cases maybe where,
right,
and most of it would be just like interesting explanations to the patients rather than helping you make a clinical decision. So that's kind of what we're seeing here. In that, if you ever wonder, well, how can I have the confidence in the PA that I have in the doctor who supervises them? It's that. That's what it is. They're able to practice the day-to-day primary care stuff under the supervision of a physician and get as good results as sometimes their studies anyway suggest, sometimes better.
Yeah.
And I think part of that has to do with time. And then of course, that's why we orient our place here to have those long appointment times where we see like maybe 2/3, 3/4 the number of patients as the other places similar to ours. Okay. Mm-hmm. Whoa, Lindsay's talking here. Let's see what Lindsay's saying. I think I'm talking about a different tax bracket than you guys are. Yeah, absolutely. When she says nobody can afford, there's certain tax brackets where you're not affording. I don't know if there's any states where medical school is super affordable anymore.
Maybe Utah.
It used to be. Well, it used to be.
Maybe.
How many years ago?
I don't know why I think of Utah. I think of like state schools. But even the state schools in California, at least, are
they're expensive now.
Yeah, medical school, state schools.
Were they when you went to medical school?
Not as much as the private school I went to.
I think I remember.
But they were still maybe $30,000 a year.
In the early 90s, I think tuition for the state medical schools in California was around $8,000 a year.
I'm going to look it up.
I think that's what I remember it being. And for private medical schools, it was more like $20,000 a year. That's kind of the range back in the early 90s. And it's gone up. Obviously, it's gone up if people are coming out with $500,000 in debt. So you talked to somebody today that's...
Yeah.
Wow.
Currently, UCLA School of Medicine in-state tuition is $42,568 a year.
In-state tuition. Wow.
That's less than what my private school was back when I went.
Wow.
What was that, 15 years ago?
Man, okay.
Anyways.
And then Robert Antonio says, from the standpoint of mental mental taxation. What is harder to wrap your brain around? What is more difficult, a general practitioner or a specialist?
It's different.
Interesting. That's
so specialists definitely require more training and are very, very good at a very specific,
very narrow
area of medicine. So we're kind of like jack of all trades, master of none, if you want to think of us. We know. There are some things we know a lot about. But we know a little bit about just about everything. Like if you come into our office, we know what to do with just about anything that comes in our office.
Well, if what to do,
and some of that is to send you to a specialist.
If it's knowing which direction to point them in.
Yeah. Sometimes that's what it is.
Or what tests to start.
Yeah. So we have like this broad kind of superficial, level of knowledge, whereas specialists have this very narrow, deep level of knowledge, and they are very good at what they do. We are eternally thankful for our specialists and their knowledge of what they do, and we use them for that when it is beyond, what we're capable of doing.
Yeah.
It's different now. It could, maybe a better question is, could a specialist easily transition to what we do versus us doing to a specialist? I think it would be easier for a specialist to do what we do than for us to learn everything that a specialist does. We would have to go.
Yeah, I think I'd agree because we're not as far beyond all of the different subjects in medicine. Mm-hmm. Whereas they are so far beyond
in that one
narrow field, and even narrower and narrower. Like the problem that we have with neurology, where you try to send a patient to a neurologist for a particular problem, and the neurologist says, "Oh, I don't do that kind of neurology."
Right? Yeah. Subspecialists within the specialty. Yeah.
So now it's it's quite something.
Yeah. You don't really hear primary care doctors do that much. I don't.
In general, you've got the ones for adults and the ones for kids.
General, yeah, I guess so. Yeah.
Internists and pediatricians. So there's a primary care division there.
Yeah.
And then you've got in family medicine, you've got those precious few family medicine docs who do OB or hospital.
In family practice, I feel like we do a little more in the way of procedures than internists. We're trained a little more in procedures. Like we can.
Interesting.
A lot of family practitioners come out. We're able to do the skin procedures. Some do vasectomies, circumcision.
Yeah, they've had more surgery exposure than your internal medicine residents have. Okay.
It's a great question. Nice thought exercise, but.
So here's the other part of that, though. I understand what you were saying, but compared to a specialist where it's narrow, what they're working with, they keep doing the same thing over and over and over. They've seen a lot of, we'll take, for example, the orthopedist who works on shoulders. He's seen a lot of shoulders.
Sure, yeah.
And lots of different complications and lots of different ways of doing shoulders. Lots of things, but how much really can happen to a shoulder? If they're to go into primary care, now all of a sudden it's everything for the whole body.
Right.
And
we're not just talking.
Or how about those cases where they come in
bones? We're talking.
And it's some real general constitutional symptoms.
Oh man.
Things like dizziness or fatigue, where the differential is pages long.
Yeah.
And you will not, at the first visit, have the diagnosis. And in fact, should not have the diagnosis at the first visit, because it means you're taking a stab instead of actually making sure you don't miss something. Yeah. So that's some perspective on that. Robert Antonio also says, I notice more DOs being listed on the hospital websites versus MDs. Is there a cost difference for I'm glad you brought that up. So osteopathy, doctor of osteopathy, has come along now here in, the last century. Early on, kind of associated with chiropractic practice because there were some similarities in what was going on there. But in contrast to the chiropractic world, they embraced evidence-based medicine and what we would call allopathic or similar to allopathic. That's what we call somebody with a degree of medical doctor, an allopathic physician, whereas the osteopathic comes from that other background. Nowadays, very, very similar. In fact, would you say most residencies are as open to osteopathic applicants as they are to allopathic applicants?
I think so.
Certainly in my residency, we had, it was in the early days of being open to bringing the DO students in. And so we were side by side in our residency. I think you were too in your residency.
Yeah. Mm-hmm.
And in the surgical residencies, I see it a lot also.
In my residency, this is just a little look behind the curtain there. They were more apt to accept a DO from a United States school versus an MD from a foreign school.
Yeah, I can see that. Yeah. So as far as seeing more, I don't know that you're seeing more, or I'm certainly not seeing more than medical doctors anywhere, but seeing both. Now, I would say as far as the growth of new programs or new schools, I think there's probably just from
personal experience,
personal experience. I think I may be witnessing more new schools opening for osteopathic medicine than new schools opening for allopathic. But I could be wrong.
I couldn't say.
It's just kind of a general impression that I have.
Don't know.
Certainly, we would hire an osteopathic physician as quickly as we'd hire an allopathic physician.
And I refer to
for our position here,
DO specialist, just like an MD specialist.
I actually sometimes get surprised at seeing somebody's credentials and go, "Oh yeah, you were a DO. I forgot." Because it doesn't matter.
They go through the same residency. As
they have
MDs.
the same.
Yeah.
Same. They need this. Or I shouldn't say same credentials. They have to jump through the same hoops after.
Yes.
They get that
same
degree.
licensure, same board certification, that sort of thing.
Well, no, you can have a DO specific board certification for some specialties.
Okay.
I don't know if that's still the case, but that used to be the case. I'm thinking mostly about emergency medicine because that's what my residency was in, and I do believe they had their own residencies in emergency medicine at that time.
They
this
did
was
more
early
like
90s.
manipulation and osteopathic type stuff.
They were probably tested on it, but as far as actual practice, I have not found the DOs to make wide use of the bone manipulation.
It's pretty rare that I see a DO that does like that sort of thing.
Yeah, and if they do, it oftentimes it's like a big deal that this is a big part of our practice, and they get people coming in that aren't necessarily their regular patients or something like that to be able to get that manipulation. Which I would be much more comfortable getting that if I was to get manipulation. I'd be much more comfortable getting it through somebody who with the osteopathic route than going to a chiropractor.
Rather than chiro.
Yeah. Okay, so that kind of covers that question of things. And then Lindsay Antwine, imagine how advanced we would be in medical science if everyone had equitable access to education. I don't know that there'd be a huge difference in the advancement of the science necessarily. I think there's potential there could be.
Yeah.
But it would be great if...
I think at this point there's actually more women in medical school rather than men, as far as like a gender equitability.
My class in the 90s was 50-50.
Mine was 2. I think just generally in the U.S. population, U.S. medical schools, it's more women than men currently, and has been growing. I've heard that. And has been growing. I believe. Yeah,
I think that's also true for college.
I don't know about like race. I don't know statistics, but I do.
Yeah. We do not have the same percentages getting into medical schools
as what's in the population. I think I have heard that. Yes.
Specifically, I'm familiar with Latino and
Hispanic,
even worse, Latina. As far as the percentage, it's dramatic how underrepresented Latinx individuals are in medicine in California,
which is
one of the focuses of the Thomas and Jill Schroeder Scholarship.
Right. Yeah.
And the applicants that they focus on.
Yeah.
Trying to get some specifically Latina medical professionals back into our community to inspire the next generation to say, hey, I can do that.
Yeah, we definitely need that. Yeah.
Okay. Well, thank you for that discussion, Robert Antonio and Lindsay Antwine. be sure to look at that Patreon. I'll show you where it is again here. I don't know. Why am I so focusing on the Patreon?
Tell all your friends in medical school
There
to
you
go
go.
into primary care.
Please. Well, how are they going to afford it? Maybe we need to focus on telling our legislators
Tell your representatives to
and bringing it up when
have good reimbursement.
when you have any interaction with them. Hey, how are we going to get people encouraged to go into primary care medicine? That's my thought. Okay,
That sounds good.
Good. Thank you, Dr. Wade.
Yeah.
And thank you, Lindsay Antoine, Robert Antonio, and the rest of you watching. Until next time,
Yeah, I'm Dr. Gawain Bond.
and Dr. Mark Vaughn telling all of you to stay in good health.
Doctors, thank you for another informative session. Auburn Medical Group is located in Auburn, California, USA. Thank you for participating. Please tell a friend and join us again next week.